Thanks for tuning in for this presentation entitled Living with Hemophilia. My name is Sean DeFreitas. I'm a clinical pharmacist. I currently work at Barnes Jewish Hospital in St. Louis, Missouri, where I specialize in oncology and more specifically bone marrow transplant and hematologic malignancies. I completed my residency training, both PGY1 and PGY2, in hematology oncology. That's really where I first became interested in this disease state and these treatments for the disease states. I have the objectives listed here for you. So by the end of the talk, I'd like for you to be able to describe the etiology and the epidemiology of hemophilia, and also list some indications for prophylaxis in the management of hemophilia. We're going to compare and contrast the pharmaceutical options for treatment and also for prophylaxis of hemophilia. And we're going to outline the role that pharmacists can play in counseling hemophiliac patients on lifestyle changes, drug treatment strategies, and medication adherence to hopefully improve quality of life. I think you'll find this talk will span both inpatient and outpatient management of patients. I hope to tailor it more towards the outpatient approach to this disease state and these patients. So hopefully you find this helpful in that regard. So there's various inherited bleeding disorders that patients can acquire. I have listed here the most common. Von Willebrand's disease, which we're not really going to talk about, which is due to a deficiency in von Willebrand factor, is the most common inherited bleeding disorder. Hemophilia A and hemophilia B are the two most common types of hemophilia. You'll find that patients can have both inherited and acquired. However, what we're going to discuss is inherited or congenital hemophilia. Hemophilia A refers to patients who have a deficiency in their coagulation factor 8. This can otherwise be called anti-hemophilic factor, or AHF. Hemophilia B patients, on the other hand, have a deficiency in factor 9. This factor 9 can also be referred to as a Christmas factor. This was named after the first patient back in the 1950s who they described this disease in. His last name was Christmas. Both hemophilia A and hemophilia B are X-linked diseases, meaning they're passed on by the female, and they can range in severity from mild to severe, and we'll discuss that. Hemophilia C is much more rare. It's actually a deficiency in factor 11. We won't really get into that because it's rare. It's often mild. There's definitely a number of other inherited bleeding disorders. The majority of them they're all very rare. The majority are inherited via autosomal recessive trait, which again makes them quite rare. Looking at the epidemiology of the disease, you see that the disease is much more common in males, and we'll talk about why that is, and that hemophilia A is much more common than hemophilia B. So you see that hemophilia A occurs in about 1 in 5,000 male births, whereas hemophilia B occurs more in 1 in 30,000 male births. Overall, if you just look at hemophilia, it occurs in about 1 in 10,000 births, so not very common altogether. Certainly the United States is only one location that has patients with hemophilia. We only have about 20,000 patients estimated in the United States with hemophilia. That's either A or B. Whereas worldwide, there's about 500,000 patients. So this is a disease state that you can see in both developed or developing countries, which can definitely affect the therapies that are provided. Our talk is mainly going to focus on the management of patients generally in the United States. And again, I emphasize that hemophilia A is about 4 times more common as hemophilia B. So how does the disease occur? What is the etiology? So as I mentioned, it's located on the gene for these diseases is located on the X chromosome. So it exhibits a sex-linked inheritance. This disease mainly affects males, as we saw on the epidemiology slide, and that is because the gene is located on the X chromosome. I have a picture here for you in a few slides that'll make things more clear. As we discussed, it exhibits a heterogeneous severity, so you can have patients anywhere from very mild to barely noticeable to patients who are extremely severe, very severe disease. The genetic mutation that occurs in either the gene for factor 8 or the gene for factor 9 really determines the severity. So there's been hundreds of mutations that have been found that cause hemophilia. These mutations, for example, point mutations, deletions, or insertions in that particular portion of the genetic code. Based on this mutation, there may be partial activity of factor 8 or factor 9 produced, or there may be none at all, it may be completely absent. So that is how the severity is determined. Interestingly, about a third of patients have no family history of hemophilia. So not only can this disease be passed on, but it can also spontaneously occur. So that would be mother and a father who have no history of hemophilia, are not carriers for hemophilia, and their child develops hemophilia. The next slide shows a little more visual for the inheritance of this disease. So as you can see on this slide, in a situation where a father does not have hemophilia and a mother does, or I'm sorry, a mother is a carrier for hemophilia, you have a normal XY in a male, and the female you have one X with a deficient hemophilia gene and a normal hemophilia gene. So that mother would be known as a carrier. So she likely does not exhibit symptoms of hemophilia. Now, what is the probability that their child is going to have hemophilia? Well, as you can see, males would be the only ones that are affected. Because the females get two X's, one from the father and one from the mother, the father does not have hemophilia, then the females would not receive a X chromosome with the hemophilia deficient gene on there. So if you look at the children that this mother and father could have, there's a 50% chance that if they have a male, that male will have the disease of hemophilia. There's a 50% chance if they have a female that female will be a carrier, and a 0% chance that female will have hemophilia. Now, in a different situation where a father actually has hemophilia and a mother does not, and is not a carrier, that's a key point, mother is not a carrier, what's the probability that the children will have hemophilia? Well, as you can see, none of the children are actually affected because they're getting one normal X chromosome from the mother. So the mother is really the determinant in the passing on of this disease. Now those females are all going to be carriers, which may affect their children down the line. And looking more at pathophysiology, we know that this is a bleeding disorder. So if we think of hemostasis as it's supposed to occur, hemostasis really occurs in two different stages. The primary stage, where vessel damage occurs and platelets are recruited to the site and form a platelet plug to seal that bleed off. And secondary hemostasis, which is really stabilization of that platelet plug. And that's by the coagulation cascade producing fibrin. The coagulation cascade, as we've all probably seen pictures of, contains a number of different coagulation factors that all end in the production of fibrin. So what happens in hemophilia is really there's inadequate amounts of thrombin that get generated. So when you don't make enough thrombin, then you're not going to make enough fibrin, and that secondary hemostasis is going to fail. So the severity then would be how much thrombin can be generated. So if you can't produce really any thrombin, then you're going to have a much more severe disease. So in looking at that picture of the secondary hemostasis or the coagulation cascade, You see the pathways listed here. What I'd like to point you to is where factor 8 and factor 9 occur. So if you follow the vessel at the top left, the vessel when damaged is going to expose tissue factor. We all have a little bit of activated factor 7 in our bloodstream. So that factor 7 is going to bind a tissue factor. That will then go on to activate factor 10 to 10A and then thrombin. That's only going to produce a little bit of thrombin. So factor 10A and thrombin both positively affect that cascade. So they come up and they activate other parts of the cascade. So you can see that thrombin is going to activate factor 8 to factor 8A, and factor 9 along down the line is going to be activated to factor 9A. Activated factor 8 and factor 9 work together as part of a 10ase complex to really activate factor 10. So that process of activating factor 10 is really important to secondary hemostasis. We'll come back to this when we talk about inhibitors. So to diagnose hemophilia, it kind of depends on whether there's a known family history. So if there is a known family history and it's a concern, you can have the child tested soon after birth. And you can do this immediately via umbilical cord blood. Most patients are diagnosed based on symptoms of bleeding. So when this occurs would depend on severity. If the patient has mild hemophilia, then this diagnosis will probably occur much later in life, after some sort of trauma or some sort of surgery where excessive bleeding is seen. Patients with moderate or severe disease, however, they may be diagnosed shortly after birth. If there's excessive bruising or excessive bleeding, then that will lead these patients to be worked up. Also, when little children start crawling or start walking, this is really when you notice it falling down, noticing bruises that don't go away. So it's diagnosed via specific factor assays. So as you're working up a patient for hemophilia, assessing the factor 9 assay is going to confirm hemophilia B. So you'll get a result that's measured in international units per ml, which is then translated into a percent of normal activity. We would say that normal activity is somewhere between 50 to 150%, or 0.5 to 1.5 international units per ml. Factor 8 deficiency, on the other hand, must actually be distinguished from von Willebrand factor deficiency. So as we discussed, von Willebrand's disease is the most common inherited bleeding disorder. What happens in von Willebrand's disease is that von Willebrand factor actually binds factor 8 and extends its half-life. So if von Willebrand's factor isn't present, then factor 8 is going to be low as well. So when you have a low factor 8 level, you have to rule out von Willebrand's disease as the cause. So again, with factor 8, you'll use the same scale of 50% to 150% as normal. Moving to the next slide, you will see the severity scale and what those clinical manifestations are. So severity can be considered mild, moderate, or severe. So again, looking at that percentage of factor activity is going to determine your severity level. So less than 1% of normal factor activity is going to be considered severe, 1 to 5% will be moderate, and greater than 5 to less than 40% mild. So what does that really mean clinically? Well, patients with mild hemophilia, they tend to exhibit bleeding symptoms after trauma, after surgery. Sometimes with dental extractions this can occur, but they don't experience spontaneous bleeding. Moderate patients, they'll have excessive bleeding following trauma, following surgery, often with dental extractions. And they may experience joint or muscle bleeds after very minor injuries. So in general, they don't exhibit spontaneous bleeding, but they may be much more prone to bleeding with very minor injuries. Whereas severe patients, they can experience spontaneous joint and muscle bleeding, And certainly, bleeding after injuries, accidents, and surgeries is a big issue. So what are the complications of this disease? Well, as we talked about, bleeding, especially into joints and muscles, can happen. So bleeding into joints is really the hallmark of hemophilia. Repeated bleeding into joints can lead to long-term orthopedic damage to those joints. Patients may be confined to wheelchairs, may require joint replacement procedures, and this can obviously impact their quality of life. Knees, ankles, and elbows are the most common joints that are affected. Intramuscular bleeds can also spontaneously occur in severe patients or happen via injury in other severity patients. This can result in compression of vessels and nerves, leading to almost a compartment syndrome, which can become quite severe. So treating these bleeding events early is very important. Other complications that's more historic but can still occur is transfusion-transmitted infections. So patients are recommended to have hepatitis A and hepatitis B vaccinations. And as we talk about the various products, recombinant products are favored because of this potential complication. The last, and probably most difficult to deal with, is the development of inhibitors. And we'll talk about this more later on in the presentation. Essentially what inhibitors are IgG antibodies that will inactivate the factor replacement that you're trying to treat with. This is going to lead to treatment changes and significantly increased cost of therapy. So what are our goals of treatment? Well, you can treat really in two different ways. You can provide on-demand therapy, or you can provide prophylaxis. On-demand therapy really is providing factor replacement when a bleeding event occurs. So what you're trying to do is raise your percent factor level to what is considered to be at a clinically appropriate level. So based on the bleed that is happening, there's different recommendations as to what percent that factor level should be at. So if you think of a more severe bleed, such as an intracranial hemorrhage, that target is somewhere 80 to 100%. The goal is to treat bleeds, obviously, if they're life-threatening immediately, and also bleeds that are not life-threatening, but can significantly damage a patient, such as joint bleeds. You should be treating those early and routinely. Prophylaxis, on the other hand, is actually providing factor replacement to prevent spontaneous bleedings from occurring. So as I mentioned, patients that have spontaneous joint bleeds, especially recurring joint bleeds, they can have joint damage that leads to severe orthopedic damage that may require surgery or the use of even a wheelchair. So the point with prophylaxis is to provide therapy to prevent those bleeding events from even occurring. I think it's always nice to look at where we've been in terms of treatment to understand where we are today. So if you look back, the 1970s is really when the modern treatment era of hemophilia began. What happened back in the 70s is they pooled together plasma concentrates from donors and they infused those into patients with hemophilia. So they started the practice of on-demand treatment with these plasma concentrates. So what happened is it helped prevent a lot of complications. Patients could be treated at home. They could be treated much earlier in their bleeding events. And so you saw better outcomes. Well, the downside to this is this pooled plasma became contaminated with viruses. We weren't as smart back then about how viruses were passed on and screening of donors and inactivation of these viral products. So patients became infected with hepatitis B and hepatitis C especially. Also, HIV became a large problem. So it was estimated that in the late 1980s, 60 to 70% of severe patients with hemophilia had acquired HIV, patients in Western Europe and the United States. And certainly if you take care of a hemophilia patient who is of that age in that era, there's a significant chance that they are actually HIV positive and are being treated for HIV. So we got smarter and we developed safer ways to inactivate viruses. Also developed more stringent donor restrictions and understood these implications. So we got even smarter in the early 90s and we developed our first recombinant product. So genetic engineering, we were able to produce these factor products without the use of donors. The first recombinant factor VIII product was released in 1992, and the first recombinant factor IX product was released in 1999. So that kind of brings us to where we are now. Now we have actually 3 different generations of recombinant products. These generations differ based on the fermentation process, the purification process, the stabilization process. And essentially, in a simplified manner, you can think about the generations. As they increase, you're moving away from human and animal proteins. So as you can see, in first generation recombinant products, they were fermented with human albumin and stabilized with human albumin. Now, in the spirit of avoiding the possibility of viral transmission, we've gone completely away from any protein, from any human or animal proteins. So third generation, as you can see, it does not include any of those. So what I have listed next is really a slide of the various products that are available. I hope I captured all of them that are out there. But as you can see, there's a number of different factor VIII products and a few different factor IX products. In factor VIII, there's 5 different types of recombinant products, and in the parentheses next to those products, I have listed a generation. So as you can see, there's a couple different third generation recombinant products. We also still have plasma-derived products. So these agents still come from plasma. However, the technology for inactivating viruses has gotten so much better that these are generally considered to be very safe. As I mentioned before, the association with factor VIII and von Willebrand's factor, there's actually products that contain increased amounts of von Willebrand factor. These are generally used for patients that have severe von Willebrand's disease. You can replete both their von Willebrand's factor and their factor VIII at the same time. Going over to factor IX, we have both recombinant and plasma-derived products available. Razubis is the newest agent on the block, and it's approved for a number of different indications as you see there. So how do you make treatment decisions based on all of these? Well, there is some controversy in that. If you look at the 2 big groups that produce guidelines for hemophilia treatment, they have differing opinions. So the National Hemophilia Foundation, their guidelines, made by their Medical and Scientific Advisory Council, suggest that recombinant products are the treatment of choice. So based on the theoretic possibility that plasma products could pass on viruses, they recommend recombinant products. The World Federation of Hemophilia, on the other hand, they place no preference for the choice of recombinant versus plasma-derived product. So depending on which guideline you look at, may differ in your treatment decision. In general, from my understanding, most patients that if they're in this era, if they're started on factor replacement therapy, generally receive recombinant products. So what factors may come into play when choosing between these different things? So availability, obviously. This comes more into play for patients in various parts of the world. So developing countries certainly wouldn't have the same access that we have here to the various types of products. Cost is something else to consider, and that would be both cost to the healthcare system as well as cost to the patient and how much they would have to pay after insurance, etc. There's also thought that the different products may establish inhibitor development differently. So as you move away from human protein, potentially you may develop more inhibitors. That's not really been shown. And there's a review article that I've cited down here in Blood by some folks in Europe that state that that really should not be a basis for a treatment decision currently, because we don't really know that for sure. The main point that I would say is that you're consistent with your treatment. So when patients are started on a product, they get very used to that product. And as long as they're happy with that factor replacement therapy, then they're generally going to want to stick with that product. I've seen patients that know, exactly what their product is, exactly how they mix it, exactly how they give it, exactly what their dose is, and they tend to know probably more about it than what you will. So in terms of dosing, factor 8 and factor 9 are dosed a little bit differently. So they're based on expected increases that you would see in your percent factor level. So factor 8, you believe that a 1 unit per kilo dose is going to increase your factor level by 2%. Therefore, you would dose based on the percent that you want. You would divide that by 2 and give you your unit per kilo. It's generally dosed every 12 hours because the half-life is somewhere between 8 to 15 hours. Now, factor 9, a 1 unit per kilo dose is going to give you a 1% increase. So whatever increase you're looking for, percentage-wise, that should be your unit per kilo dose. Factor 9 is dosed typically every 24 hours because its half-life is that, 24 hours. Now this is based on population, of course. So it's stressed that doses should be individualized based on pharmacokinetics. Really what you're looking for is trough-guided pharmacokinetics. So you can assess the max, the Tmax, or what's known as the in vivo recovery, about 10 or 15 minutes after the dose, and then again at the end of your interval. You can calculate an elimination rate, and you can then know what your level is at the trough. So depending on what you're treating or prophylaxing for, would determine what you want your trough really to be. The one stipulation with recombinant factor 9 is that you have to multiply your calculated dose times 1.2 if you're using a recombinant dose. For some reason, recombinant factor 9 experiences about 20% less in vivo recovery than what's expected. So you multiply by 1.2 to make up for that. So I was talking about targets before for on-demand therapy. What you see listed on this slide is indications or types of hemorrhage and what the recommendation is for a target level and for a certain duration based on the World Federation of Hemophilia guidelines. So you can see a CNS bleed with target levels that are much higher, whereas a joint muscle bleed with target levels that are more around the 50% range to get you really to the lower limit of normal. So these are available to you if the situation arises. And what about prophylaxis? Well, so prophylaxis can be defined differently. So you can have primary or secondary prophylaxis. Primary prophylaxis is defined as starting prophylactic therapy before their second clinically evident joint bleed. Secondary would be starting after 2 or more joint bleeds. That's a little bit simplified because there's also some age variances that can come into those definitions, but I think that's the main takeaway. Severe hemophilia A or B is the recommendation for prophylaxis. The recommendation is to institute early prior to frequent bleeding, which makes sense, prior to that joint damage occurring. If you're giving factor 8, you generally give somewhere between 15 to 50 units per kilo, either 3 times a week or every other day, and you would base that off of the personal pharmacokinetics of that patient. Factor 9 is generally just dosed 2 or 3 times a week, somewhere between 50 to 100 units per kilo. The one thing that we really don't know is what the adequate duration of prophylaxis is. So if you started in a patient who is, for example, a year old or a year and a half old, how long do you continue that? How long are those benefits seen? We don't know that answer. So really the goal with prophylaxis is to keep a trough level above 1%. So as I mentioned in the severity slide, moderate severity patients typically do not experience spontaneous bleeding. So really the goal is to provide prophylactic factor replacement to essentially move those severe patients into the moderate severity group. And again, you have to individualize your dosing to make sure that this occurs. So what is the evidence for prophylaxis? Well, there's a 2007 study in the New England Journal of Medicine that looked at giving 25 units per kilo every other day. This is in hemophilia A patients. The primary outcome was looking at preservation of index joint structure via imaging. So essentially, taking a look at MRIs and seeing whether joint damage has been occurring. What they saw using this prophylactic approach was that an 83% relative risk reduction in joint damage as determined by those MRI readings. I should mention that these patients, there were 65 patients in this study, and they were less than 30 months old. So we're looking at a very young patient population. The table below shows the other various outcomes. So joint damage, you saw 45% of patients that did not receive prophylaxis experienced joint damage, compared to 7%, which was statistically significant. Joint hemorrhage was also statistically significant, really reduced in the prophylactic group, as well as total hemorrhage. So if you're looking for the reasoning for the prophylactic use, I would look to this study. Cost effectiveness is perceived to be a benefit also. So even though you're going to pay more for the factor product itself because you're giving it on a normal scheduled basis, the thought is that the cost reduction in terms of health outcomes down the road results in cost effectiveness. Moving on to the topic of inhibitors. So as I mentioned before, inhibitors are really IgG antibodies that are recognizing this factor product as foreign. So usually you notice patients having minimal clinical response to factor VIII or factor IX infusions. This could be in the prophylactic setting or in the on-demand therapy setting. The incidence really occurs much more in hemophilia A. So about a third of patients with hemophilia A could develop inhibitors, which is a pretty significant number. Hemophilia B is much less often, around 5%. There's a number of risk factors that have been proposed and hypothesized. The type of mutation that caused the hemophilia, what type of treatment you've gotten, the amount of treatment that you've gotten, race, ethnicity is also potentially thought to play a role. The bottom line is we don't really know for sure, although mutational defect is probably a consideration. So what happens? Why is the development of inhibitors so bad? Well, you're much more likely to be hospitalized with a bleeding episode, and your cost of care significantly increases. Inhibitors are measured by units called Bethesda units per ml. So you'll see this reported out as a number per Bethesda unit per ml. It's broken down into low or high titers. This is defined as less than 5 or greater than equal to 5. This is an important number to remember because this influences therapy. So if you're considered to have a low titer or less than 5 Bethesda units per ml, then you can actually replete with factor VIII or factor IX efficiently. You may need to give a little bit of an extra dose, but you're still able to overcome those antibodies that are present. Now, if you're 5 or above, you really have to use a bypassing agent. So we'll look at the coagulation cascade again, but essentially you avoid factor VIII or factor IX products. That would be in the acute setting, and then more in the chronic setting, you would look at ways to reduce those antibodies. So again, looking at that coagulation cascade, what you're trying to do is avoid that factor 8, factor 9, 10-ACE complex that we talked about before. So what you can do is actually give activated factor 7, which as I mentioned binds to tissue factor there. But if you give enough activated factor 7, then you're able to produce enough thrombin and therefore fibrin. The other method is by giving an agent called factor 8 inhibitor bypassing agent, which supplies various types of coagulation factors that would allow, again, that process to be overcome. So really with on-demand treatment, those are the two agents you can use. Recombinant factor 7 is exceedingly expensive. You have to dose it often. It's typically dosed at 90 mics per kilo. This is usually every 12 hours until hemostasis occurs. Patients that are going to surgery, this also is quite difficult. You can actually use continuous infusions of both this product and also factor 8 and factor 9. But for patients with inhibitors, you would obviously be using one of these bypassing agents. So the FIBA, or the factor 8 inhibitor bypassing agent, as I said, it provides different coagulation factors. So you're actually going to get thrombin, or factor 2, factor 7, factor 9, and factor 10, which should allow you to overcome that 10-ACE complex being present. You would obviously only use this for patients with hemophilia A because this includes factor 9 in the product. The dose would be 100 units per kilo as a single dose with a max of 200 units per kilo per day. And that max is a hard stop because increased risk of thrombosis is seen. So immune tolerance, I'm not going to spend much time on. There's a number of different ways to go about it. None really been shown to be all that better than the others. You can use high doses for short periods of time. So really what you're doing is you're exposing, for example, if this is hemophilia A with inhibitors, you'd be exposing this immune system to high doses of factor 8 in hopes to overcome those antibodies and allow them to recognize or to no longer recognize the product as foreign. You can also combine it with immunosuppressive therapy. Removing actually the B cells is a method that's been shown to be somewhat effective. And so using a product like rituximab may be of some benefit. About 20%, these numbers definitely vary depending on what you read, but 20 to 40% of patients may fail. And we really haven't figured out the ideal product, the ideal dose to perform with this immune tolerance induction therapy. So as I mentioned, those cost considerations, when patients have inhibitors, especially the inpatient costs significantly increase as patients are certainly going to be inpatient for their bleeding events, and the therapies are much more expensive. Some alternative therapies that you may see in the community, desmopressin. Desmopressin is a synthetic analog of vasopressin. It will actually increase factor 8 and von Willebrand factor in the plasma. So you can use this for mild hemophilia A, potentially for moderate hemophilia A as well. And this is really a nice cost-effective approach if it works. Before doing something such as surgery, you should definitely understand whether the desmopressin is going to work in that particular patient. It can be given sub-Q or intranasally. Something to note, because there's different indications for desmopressin intranasally. Stymate is the brand name of the product, and it's a higher dose, so it's 1.5 milligrams per ml concentration. So that's the product that you would be giving to a patient for hemophilia. Depending on their weight, they may get a spray in one nostril or a spray in each nostril. Antifibrinolytic agents, which really help to stabilize clots once they're there. You have both aminocaproic acid or tranexamic acid. These are really, mucosa type bleeding, so in the mouth, bleeding around menstruation. I've listed some doses here for those. Could also see these agents around dental extractions, maybe a common use. Something also to know is, patients should not be taking aspirin or NSAIDs, especially if they have severe hemophilia, unless it's approved by a hematologist. I say that because these products have platelet inhibitory mechanisms associated with them, and so you may increase your chance of bleeding. So looking at medication adherence, how can you improve your patient's medication adherence or just discuss with them up front? The clinical consequences are quite apparent. So if patients have had bleeding events before, they know what those are like. So you can, really stress that, how bad they felt with that bleeding event, or relating it to someone who's not had a bleeding event. You can educate them on what those consequences can be if their medication or their factor replacement isn't used. There's both short and long-term benefits. As I mentioned, the short term of treating your bleeding events urgently or prophylaxing for those bleeding events can certainly prevent you from developing things such as joint damage down the road. Education of both parents and caregivers is going to be important. A lot of times these patients may be extremely young, so having parents that are there, having other caregivers that may be present in the household, present while the education process takes place is definitely vital. Providing both emotional and social support for these patients. So while this may not be all on the pharmacist, it's definitely something that the pharmacist can touch on, ensuring that patients either have access to this support or helping them find access to this support. Appropriately performing access to their veins or the management of their implanted venous access device in terms of making sure it's adequately cleaned, what are some of the signs, symptoms of thrombosis, things like that. And again, stressing that on-demand treatment needs to be immediate. If in doubt, treat. So in terms of the drug treatment, some teaching points, general knowledge on hemophilia. If patients haven't been educated, it's good to come from the basics. Teaching them to recognize bleeding events. So things such as pain, tingling, redness, all of those things can help them understand maybe what those bleeding events feel like. Patients that have had them will know. Helping them calculate doses, so especially around times when maybe doses have changed or weight has significantly changed. Ensuring that those patients know how to calculate their doses would be important. Appropriate storage and administration based on what type of access they have and what product it is, I think would be important, as well as the appropriate disposal of needles, making sure that they have access to a sharps container if needed based on the product. Another neat thing that you can have patients do is keep an infusion log. An infusion log is going to record date, time, number of infusions and bleeds they've had. This really helps a physician understand what's happening with the disease process and may guide treatment. Adverse effects with the products. Hypersensitivity is something that can happen. So if a patient's getting a new product or a different product, hopefully they've received it in the presence of medical care. If not, that's something that you would want to counsel them on understanding these signs and symptoms of that and what to do if that occurs. Various lifestyle practices. So as you're counseling them regarding the drug treatment, you can mention these things as well. It's recommended to participate in regular activities. If patients are going to be involved in high contact sports, then prophylaxis may be something that they should discuss with their physician. But definitely working on their strength, working on their conditioning, getting out, being active is very beneficial. Again, the catheter care, and I would refer them to the various websites for the National Hemophilia Foundation. If they don't have access to the web, then you can access this for them. But they provide kind of education packets for lifestyle practices, such as things that you wouldn't even ordinarily think about, like finding childcare. What are some directions for first aid for your child's school? Things with home infusion, etc. The other thing is to carry easily accessible identification. So a method of if the patient is not conscious, that the medical personnel can understand what their disease process is. Finally, they also mentioned standards of service for pharmacy providers. If you're interested in this, I would go to the website listed here. Essentially what they're saying is that pharmacies that are supplying these products and for patients with hemophilia, the staff should have an adequate knowledge of the clotting factors and the supplies necessary. They should actually have the clotting factors and the supplies. the ability to process the orders efficiently and effectively, have appropriate hours and availability to provide care to these patients, potentially a delivery service to get patients products at home, and then keeping adequate records and bills, etc. So again, points of reference, I would guide you to these different websites, and you can point these websites to your patients as well, because they're definitely of appropriateness for patients. So that concludes what I have. I appreciate, again, you guys tuning in for this presentation. I hope I was able to guide you in the right direction, teach you a few things that you didn't know about hemophilia. Thank you.